We did the first kidney transplant in 2011. My wife was a match for me. She gave me one of her kidneys. My transplant kidney lasted almost 10 years. I have a particularly high sensitivity to tacrolimus, one of the key anti-rejection medications.
Okay.
So that caused a lot of damage to my kidney, and it's not known whether or not that particularly high sensitivity is associated with the FLD or if it's just unique to me. But that ultimately, that in combination with the continued progression of my disease continued to do damage to the transplant kidney. So 2020, I was in end-stage renal disease again, and we did a second transplant in 2021. And my sister-in-law was kind enough to give me one of her kidneys. So, I'm burning through my family's spare parts pretty quick.
Hello and welcome to Cure Talks. This is Priya Menon, your host. Today on Cure Talks, we are discussing a very rare disorder, namely the lecithin cholesterol acyltransferase deficiency disorders, or the LCAT deficiency disorder. We have with us Professor of Medicine, Dr. Marina Cuchel from the University of Pennsylvania. Dr. Cuchel's research focuses on novel therapeutic strategies for the treatment of rare genetic disorders of lipid metabolism. Joining Dr. Cuchel on the panel are advocates Jason Marshall, who lives with LCAT deficiency disorder, and Beverly Ridings, who was a caregiver to Jason. Welcome to Cure Talks, everyone.
Thank you.
Thank you. Thank you. Welcome. And thank you for hosting us, Priya.
Lecithin cholesterol acyltransferase deficiency disorders, or the LCAT deficiency disorder, is a very, very rare condition with less than 125 known cases the world over. Dr. Cuchel, to start with, let's understand what this condition is all about. Can you explain in layman terms what LCAT deficiency disorder is, which part of the body is affected, and what causes it?
Priya, thank you very much for giving us this opportunity. I really hope that through this conversation, we can really increase the awareness of this, as you said, very rare condition. So much so that the medical term for this very rare disease is ultra-rare disease. So we are talking about an ultra-rare disease. So what it is, LCAT deficiency is caused by the complete or partial absence of this protein that, as you said, is called lecithin cholesterol acyltransferases, or LCAT for short, due to a mutation in the gene that contain the information for the cells to produce LCAT. And so what happens when LCAT is not present? LCAT is produced by the liver and is secreted in the circulation and has a very, very, very important function in circulation. And that is that of trapping cholesterol inside some complex molecule that are called lipoprotein, that trapping the cholesterol are able to take it back to the liver to be eliminated. And you can think, oil and water do not mix together, and cholesterol and triglyceride and other fats are fat, like oil, that cannot mix well in the bloodstream. So they need these complex particles, lipoprotein, to circulate and be safely deposited in the liver where they can be excreted and processed to be eliminated. So when LCAT is absent, the cholesterol cannot be trapped. And so it gets deposited somewhere in the body. And there are two organs that are preferentially targeted and creating damage, potentially creating damage. And so all patients, all people that have LCAT deficiency have two characteristic features. One is that they have very, very, very low level of a lipoprotein that is called HDL. and in particular, the cholesterol that is carried by this HDL. So they have very low level of HDL cholesterol. And the other characteristics that every patient has is what is called corneal opacity. That is practically a clouding of the corneal, that is the most external part of our eye. And so these patients have a bluish, grayish hue, shade on their eye. So these, and maybe an increased risk of heart disease, is what the people that have the milder form of LCAT deficiency, that is called fish eye disease because of the characteristic of the eye, or FED for short, may have. But there is also a more severe form of LCAT deficiency. Is called familial LCAT deficiency, or FLD, that has two other signs and symptoms that can occur. One is anemia, because too much cholesterol is deposited in the membrane of the red blood cells that are, and make them very easy to break. And so there is anemia. And the other organ that is terribly affected is the kidney, because the excess of cholesterol go and get deposited in the kidney and is toxic for the cells of the kidney that then die. And so there is a renal kidney disease as a consequence. So this is what LCAT is, and what are the cause of this condition.
So, Dr. Cuchel, you said some of lower levels of HDL and opacities in the eye. Are these the signs and symptoms, or is this a much progressed version of the disease? I'm just trying to understand, if I want to get tested, what is it that I should be looking for? What should be that indicator which tells me, yes, I should get tested?
Priya, thank you very much for asking this question. This is really important. It is very important because these conditions usually are diagnosed too late. When some people, for example, with FLD, notice that their ankle gets swollen because of the kidney disease. And so many times, the few patients that we know of, many times they are diagnosed because they already have the manifestation of the disease. And until that moment, the disease was silent. So how we recognize? We need to be better at recognizing this condition. Both the patients need to be, more advocate of themselves, and the doctors that this is patient need to learn how to recognize the disease. And so the first thing that I say to you, the first sign that usually appear is this corneal opacity, this cloudiness on the eye, that usually become apparent during the early teenage year. And unfortunately, because they do not create big problem to see, of the vision, they frequently are not investigated. This appearance of this strange hue in the eyes is usually not investigated further, or if it's investigated, it's thought to be something else, maybe a senile ARCOS that is frequent in people with very, very high cholesterol levels, or in the older patient. The other bell that should ring in our head is if you do a lipid panel, if you look and have the doctor that prescribed to you a blood test to check your cholesterol, you will notice that your HDL are very, very low. And unfortunately, although many guidelines say that a lipid screening, a blood test for lipids should be done in school age years and young adult, it's rarely done. And so many times this is discovered because someone in the family has heart attack or have renal disease or something that prompted the doctor to say, okay, let's see if other members of your family have this. And so during this screening that is called opportunistic screening, you may discover that one family member also have very low HDL level. And in that case, it should be, follow-up should be done to try to discover why these patients have low HDL. And so a clinical confirmation of the presence of LCAT deficiency is to test in the blood how much activity the LCAT has, how much LCAT activity is present in the blood of the person that you want to test. This, however, is a very, very specialty test. Only few labs in the whole world are doing it. And so it is easier, if available, doing a genetic testing for all and tested for all the genetic cause of low HDL, including LCAT. And so you can diagnose LCAT deficiency through that. If neither of the two tests are available, usually you arrive at the diagnosis putting together all the pieces of this patient, the low HDL, the renal biopsy, if the person has started to have renal disease, the anemia, the corneal opacity, and you make the diagnosis of LCAT deficiency.
Thanks, Dr. Cuchel. Beverly, we would like to really hear from you. I've heard from Dr. Cuchel how you advocated for getting Jason tested, and I think it'd be really great hear your side of the story, how it unfolded. Can you please share that with us?
When my husband passed away, our primary care physician said, he died pretty early. He had a pretty massive heart attack. Maybe you need to have the kids tested to see if there's anything going on with them. So that prompted us going to a major medical center and beginning this whole process of being tested. And it was a few years before a good name was given to the disease. We went through a series of a lot of blood tests, and Jason was quite young. And we did skin biopsies and cloning of skin cells and all sorts of like I said, blood tests before it really came out what exactly is the name of this disease. In the meanwhile, we realized that he has very high cholesterol, very high triglycerides, so we worked on dietary management, which is really hard to do for a young child. I could be in control of some of that, but not all the time. And while dietary management is really important, you can't fight genetics very well. If it's already there in the genes, you're just going to have to roll with it and make the best habits that you can. Diet, exercise, regular physician's visits and blood tests.
Jason, what is your side of the story? I know you were diagnosed even before your symptoms appeared, right? How has your condition evolved over the years?
Well, initially, of course, we observed the extraordinarily low HDL levels. And I believe in my teenage years, the corneal opacities began to show up. But the corneal opacities, even today, as they have progressed, have had no effect on my vision. Symptomatically, I really didn't have any symptoms until about age 29 when I started to go into end-stage renal failure. And that was the first time that I actually myself really took the disease seriously. I'm a little ashamed to admit that in my younger years, I was very dismissive of it because I was anti-symptomatic. And, you know, the young and dumb side of that equation too. Mom said young, I add to that uncooperative. and so, yeah, about age 29 was when the end-stage renal disease became very physically symptomatic, and we started looking at doing a kidney transplant. And that's when it finally clicked for me that I needed to become more proactive in my healthcare overall, and not be dismissive of this disease.
So you have undergone kidney transplant twice. Is that right? Yes, and also a liver transplant. Would you like to share that with us as well?
Absolutely. We did the first kidney transplant in 2011. My wife was a match for me. She gave me one of her kidneys. And the thinking at the time, we were working with Dr. Miller at University of Maryland. He's now working with Dr. Cuchel at University of Pennsylvania. The thinking was that there was a possibility, because there, you know, is no known therapy, no existing therapy for this disease aside from treating symptoms, that potentially if we did a liver transplant, a partial liver transplant, that maybe the healthy portion of the liver would be able to produce a healthy LCAT enzyme. And so we opted to proceed with that. And coincidentally and miraculously, my wife was also a very good candidate for the liver transplant. In fact, the surgeons at the time, the transplant team, were throwing around numbers of statistics of 1 in a billion match, from both the kidney perspective, and then to be able to do the liver as a living donor. So we gave that a try, which showed some initial success. We did a small lobe transplant, and immediately following the transplant, we had some better HDL numbers. Normally, my HDL is less than 5, and immediately in the hours following the transplant, I was as high as 17. But within a few days, that fell off back to my normal range, unfortunately. So as a form of therapy, it was not successful, and we're still not sure why. Some of the theories include the possibility that I may have developed antibodies to the LCAT. And to my knowledge, we still haven't successfully tested that theory. So that's the story of the liver transplant. And my transplant kidney lasted almost 10 years. I have a particularly high sensitivity to tacrolimus, one of the key anti-rejection medications. So that caused a lot of damage to my kidney, and it's not known whether or not that particularly high sensitivity is associated with the FLD, or if it's just unique to me. But that ultimately, that in combination with, you know, the continued progression of my disease, the continue to do damage to the transplant kidney. So in 2021, we did a second kidney transplant. 2020, I was in end-stage renal disease again, and we did a second transplant in 2021. And my sister-in-law was kind enough to give me one of her kidneys. So, you know, I'm burning through my family's spare parts pretty quick.
Thank you, Jason, for sharing that. Dr. Cuchel, I'm circling back to you a bit. What is the current stand of care? We have just heard Jason's.
Yeah, I I am truly grateful for Jason to really be so open with his journey on this disease. So he mentioned this already. There is no real cure for LCAT deficiency right now. And we can discuss then what we can do for that.
Yeah.
But so let's see, first of all, let's start really very early. What we can do to prevent passing down this condition. And so because this is a inherited disease, inherited condition, it passes when two parents pass to the child a defective gene. And so the risk factor to get this condition is really linked to the law of inheritance, right? To what is, and so if we know that we have a positive family history, either for an excess of heart disease or even for renal disease, every prospective parent should consider to have a lab test, a blood test, to see how are my cholesterol numbers. And if I found that both myself and my husband have low HDL, certainly talking to the doctors, seeing prenatal care, understanding what could be the potential consequences are very important. Especially, again, if we know that there is something that runs in the family, so we can suspect that there is a genetic condition. So if we are as lucky as Jason was, that his mom really advocated to look for the reason why Jason had these very low HDL levels. And this was a test, that she demanded to do after her husband died at a very young age of a massive heart attack. So if we are so lucky to identify a patient with this disease, or a person with this disease, because it's not yet a patient, even before any sign or symptom appear, then really, as Beverly was doing, trying to start and follow a very healthy, kidney-friendly diet will be very important, because for patients with FLD, familial LCAT deficiency, the most important goal is to try to preserve the renal function as long as possible, because the only thing that we can do once the symptoms appear is that to treat the symptoms, not to treat the cause. And so we know, for example, right now that some of the factors that may affect the progression to renal disease are associated with high cholesterol and high triglyceride, and Beverly was mentioning this to you. So not only a kidney-friendly diet, but also a cholesterol-friendly diet should be followed, right? A heart-friendly diet should be followed. If necessary, some drugs should be given to control the lipids level, right? To control the levels of cholesterol that on triglycerides that these people have. And then, of course, as soon as we start to see that the liver, the kidney may start to get damaged, and so if I follow routinely with my doctor and routinely I do blood and urine testing, and then maybe starting as soon as we can drugs that can protect the kidney. And unfortunately, these drugs are just, blood pressure drugs or diuretics, because for now we do not have much more to offer. What also Jason mentioned is that usually when you arrive to have end-stage kidney disease, then the only option that you have is dialysis or kidney transplant. And how Jason alluded to, the transplant doesn't cure the disease, because it's not tackling the cause, and it's just buying time. And so again, it's very important to maintain very good diet and lifestyle habits. Very important to follow all the prescription medication that the doctors gave it to you. But at the end, it's frequently happen, as in Jason, that you need another transplant. And in Jason's case was after about 10 years after the first one. And so this is unfortunately what we can do for the kidney. Fortunately, as Jason said to you right now, usually the corneal opacity doesn't affect too much the vision, but there are few people that are affected. In that case, you can consider a corneal transplant. And so follow up with an eye doctor, it will be very important. And the anemia is just treated symptomatically. So as you can see, all the treatment that we have now available are only treatment to treat the symptoms, not to tackle the cause of the disease.
Thank you, Dr. Cuchel. Jason, Beverly, do you have any questions for Dr. Cuchel?
Well, I think, it's always interesting to me to see what is on the horizon, technologically speaking. Is there any direction that we're heading, anything show promise for a potential form of therapy for the disease itself, instead of just treating the symptoms?
Jason, this is the $1 million question, so you know that very, very well. So there are quite a few opportunities that are emerging, but are still very far from the horizon, meaning that they are being tested first in cells and then in animals. And there are very, very, very few approaches that have reached humans, being tested in people. And when I said very, very, very few people, I really literally said less than a handful of people that receive some experimental treatment. And among these treatments, there could be a recombinant, a synthetic LCAT, that is the protein that is missing, are synthetic HDLs, but not much, much more. So your approach, I truly admire you and your doctors that really try to tackle the cause of this disease after your first transplant. And they try to see, let's see, if we gave a piece of liver to Jason, can Jason produce the LCAT that is needed to cure and treat the cause of the disease? And I mentioned earlier, LCAT is produced at the liver, so that was the rationale. Let's give him some liver to see. But Jason, as you well know, you are the N of one to try this treatment. And so it's very difficult when there is an N of one to understand if the treatment is valuable or is, can be further pursued. So you are absolutely right. There could be different reasons why your experiment failed. And one possibility is testing for LCAT antibodies, but it's a test that doesn't exist. So there is some research lab, and we are trying to do that, but it's not simple. Or maybe your body just rejected this piece of liver for whatever reason. How many transplant the recipient had problem with rejection. So we do not know. But that concept is really the base of novel treatment that may be that are in development, like cell therapy or gene therapy. But these are still so far away to be used in humans, because first we need to be, it will work in a cells, it will work in an animal, and then if everything goes well, let's try to see if we can test it in real people. And I would like to then just give a shot of what I think is one of the biggest obstacle for the development of treatment for rare disease in general, but specifically for LCAT deficiency. And it's not only that there are very few people with this ultra-rare genetic condition, is that because there are so many people all around the world, we ourselves, the doctors and the investigators and the patient, we do not know much why the disease occur, why cholesterol get deposited in the eyes and in the liver and not in somewhere else, and why some people may develop renal disease, kidney disease, and some other not, or why some people that have the same genetic defect develop the kidney disease and other no, or someone develop the kidney disease very early and some other very late in life or not at all. So all these questions are key. And if we don't know all these pieces, we cannot really build and plan for a clinical trial because we don't even know what to measure, right? We don't know how long it takes for developing a renal disease or the opacity in the eye. And so for this reason, while all the bright scientists that are working preclinically on developing this new treatment, we are really focusing all our attention to learn more about the disease. And Jason knows because I always talk to him about that. I really see this as a strong collaboration, an important collaboration between the patient, the doctor, the investigators, the advocate, to try to put together all this data and try to understand the natural history of the condition. What are the factors that affect this condition? And so we have an ongoing study that hopefully goes in parallel to the development of novel treatments. So when these novel treatments are available to be tested, we know what to look for to see if one treatment is successful or not.
Thank you, Dr. Cuchel. Thanks, Jason. That's a great question. Jason, it would be great, in fact, because you shared your story with us, your day-to-day challenges. Do you have any tips for people who may find themselves in a similar situation? Any words that you want to share with them?
Absolutely. Don't be dismissive of the disease, for one.
Yeah.
Definitely be proactive in your care management. I'd encourage anybody with FLD or FED to get involved in a research protocol such as Dr. Cuchel's. She is doing great work to extend the range of her research, and the more people we can get involved, and I think she can speak a little more to some of the bureaucratic hurdles that stand in the way of orphan diseases like this. But the more people that get involved, maybe the more success we'll have in not only understanding the disease and advancing the research from that perspective, but also advancing the research for potential cure. Mm-hmm. And to that end, Dr. Cuchel, I think you mentioned there's somewhere around 125 diagnosed cases in the world. Is there any kind of understanding of how many undiagnosed cases there might be because of the lack of understanding of the disease?
Jason, this is an extremely important question. And the honest answer is no, we don't really know how many undiagnosed patients may be there. And, I mentioned to you so those 120 cases that are reported in the literature and we know exist are over the since the 70s, when this disease was described for the first time, until now, and who published a paper is because found a case that is interested and has the opportunity to publish that case and share it with the scientific and medical community. Many people, for example, if they have FED and the only thing that they do cloudiness of the eyes, don't even go to the doctor to be tested because they do not have any symptoms. So really, we do not know how many undiagnosed patients, or also patients that get diagnosed with renal disease and never understand the cause of it. And so we believe that is very underdiagnosed. So we are seeing only the tip of the iceberg, and hopefully, if we are good on increasing awareness to the eye doctors, to the kidney doctors, to the dialysis center, to patient and patient advocate like you, hopefully we can increase the amount of people that come out of the woods and as you said, collaborate and try to advocate for the development of cures.
And I will say, from my perspective, from a patient perspective, doctors and researchers such as yourself and others who've been working in this field have done an outstanding job of informing the medical field as a whole. Because if you go back not more than 15 years, when I would walk into a doctor's office and speak with any doctor, be it cardiologist, nephrologist, anything, general practitioner, they had never heard of LCAT deficiency, FLD, or anything of the kind. But I'm happy to say that these days that is less common. I'd walk in, if I see it or encounter a new doctor, they have at least heard of it now. And so that is a huge step in the right direction, thanks to, your work and those like yourself. And I thank you.
Awesome.
We need also many patients like you that goes to the doctors and say this exists, and please make the effort so I do not have to reach a third transplant sometimes.
I try, but I can't pronounce most of the words you use, let alone understand them.
Marina, some of as we were discussing the information LCAT deficiency so well, right? As Jason said, right now, things are changing. So where can maybe patients and caregivers go for information on managing the condition? Because I'm also aware, you search on the internet, there's not much out there. So where can people go to find out more?
Priya, thank you. This is a very important question. And we, as a treating physician, researcher, and everything, we should do a much better job. So theoretically, there are two rare disease organizations. One is NORD in the United States. One is Orphanet Rare Disease in Europe. That if you go in their website and type LCAT deficiency, they will provide some information, and they will also have the possibility for you to reach and to search and link to Center of Excellence. There is always clinicaltrial.gov, that is that government-run or depository of all clinical trials that are conducted or clinical studies that are conducted for every single disease that you can think of. But if you also there type LCAT, they will come up with a group of studies that are being done with a link of contact person. And Jason was mentioning right now there start to be a better understanding, at least of the name, and so if you go to a lipid specialist should really put you in contact if they do not have any direct experience with some of the colleagues that have that experience, or some nephrologist, kidney doctor that knows this disease. I plug the last things for myself. I am available to receive any inquiry. I now have, we create a good network of international doctor and researcher that specifically work on LCAT deficiency. So also if you are in Japan, I can refer you to a colleague that is in Japan, or if in Europe, there are few groups in Europe, or in Brazil, in the States. So please do not hesitate to contact me. I'm very happy to answer any question. If you are a patient, if you are a doctor, or if you are a researcher, I'm here and I can be contactable. I'm very happy to help you out.
That's wonderful, Marina, and I hope our listeners would definitely hear that. And if they have somebody or they need any kind of information, they will reach out. So I think it's time to wrap up today's session. Marina, Beverly, and Jason, thank you so much for joining and sharing your stories with us. As Marina said, ultra-rare disease, LCAT deficiency disorder, and I hope this discussion has provided a little bit more information on such a rare condition. We thank all of you. We also thank University of Pennsylvania. This talk will be available on curetalks.com and Penn's website. Thank you, everyone. Have a great day. Thank you.
Thank you. Yeah. Thank you very much.